So it's this really, the molar concentration of CSF, of CO2 in the CSF particularly, that then hydrates and stimulates central chemoreceptors. Okay. So when patients are acidic, especially in respiratory failure, then CO2 goes up, pH goes down in response to it, but it's the CO2 that crosses the blood-brain barrier and specifically sensitive to central chemoreceptors that creates a respiratory pattern to help you blow that off. Okay, so it'll cause an increased depth of respiration. We'll breathe more frequently in an effort to bring the CO2 down. So, and as CO2 goes down, fewer hydrogen ions in the CSF, and the central chemoreceptors aren't stimulated as strongly anymore. Respiratory rate comes back up, and we regulate the amount of ventilation in response to hydrogen ions in the CSF. So it's not hydrogen ions in the blood as much as it is CO2, but CO2 is directly responsive to the molar concentrations of bicarbonate and hydrogen ions in the CSF as it hydrolyzes with CO2. So that's an important distinction. So central chemoreceptors. Peripheral chemoreceptors, on the other hand, are located in the arch of the aorta and the bifurcation of the carotid bodies near the neck and the ear. Go ahead, dear.
Sorry,
No
you might
worries.
have just explained this, but I'm still a little bit confused.
It's okay.
And it was when I was reading, but you said that it senses the hydrogen, right? But the CO2 is permeable, but where does the hydrogen come from?
From the hydration of CO2 after it crosses the blood-brain barrier. So
Okay,
there is a diagram on 372. And so as CO2 goes up, CO2 crosses the blood-brain barrier into the CSF. It's that red one right there. So as CO2 goes up, CO2 crosses the blood-brain barrier and hydrolyzes.
oh, okay, so H2O goes with it.
Yeah, so
Okay.
so it's not hydrogen ions directly. It's CO2 in the blood that crosses the blood-brain barrier, then hydrolyzes, and then dissociates into hydrogen ions and bicarbonate here.
Okay, perfect.
And that's what stimulates the central chemoreceptors.
Okay.
Okay, on the ventral side of the medulla. Okay. So central chemoreceptors are specifically sensitive to hydrogen ions, but it's not hydrogen ions that get across the blood-brain barrier, it's CO2 specifically. So our breathing rate and pattern, if I were to hyperventilate voluntarily, CO2 lowers, and that would decrease the sensitivity of the central chemoreceptors' responsiveness to hydrogen ions because of a lower CO2. Right? So it's interesting how these cells are sensitive to specific ions. Peripheral chemoreceptors, on the other hand, are more sensitive to oxygen-sensitive cells. And so if PO2s in the blood reach below about 55 or 60 millimeters of mercury, I think 55 is probably a better number. Does it give a number in the text for peripheral chemoreceptors? 60? Oh yeah, it does. 64. So 55 or 60 millimeters of mercury. Now, that's an interesting number because we live at 5,000 feet, and our PO2 yields a saturation of 90% saturation at a PO2 of 60. So we're right about there at this elevation. Certainly when we go up to Alta or Brighton, I bet our PO2s are pretty consistently in the 60s. So as PO2 goes lower, that causes sensitive cells in the peripheral chemoreceptors, the arch of the aorta, the bifurcation of the carotid bodies up in the neck, to stimulate breathing. So when we go up to elevation, we might breathe faster because our PO2 is low, not because of any association with CO2, but because our oxygen levels are low. So peripheral chemoreceptors are specifically sensitive to oxygen and to a lesser degree hydrogen ions. So there are hydrogen ions in the blood. And central chemoreceptors are specifically sensitive to hydrogen ions in the CSF. So two mechanisms that get back to our respiratory centers in the blood that stimulate and coordinate breathing. Okay. So the text talks about altitude changes and how that stimulates or by either increasing or decreasing the sensitive cells in the central portion of the human body. The central chemoreceptors then we have to associate with the brain and the medulla. The peripheral chemoreceptors we associate with receptors in the arch of the aorta and the bifurcation of the carotid body. So those are said to be peripheral as far as where they're located in the body. Central or in the brain, peripheral, arch of the aorta, and the bifurcation of the body. Hydrogen ions. The textbook talks briefly about the control of ventilation for patients that have chronic CO2 retention. And we've worried about that in the practice of respiratory therapy for quite some time. So it's not really known what the mechanism is, but you've all heard that we should be careful or judicious in the way we administer oxygen to patients, right? Especially patients with chronic obstructive pulmonary disease. All COPD patients are generally CO2 retainers. So they typically will have higher levels of CO2 because of the destruction of the alveolar capillary membrane. So they don't have as much surface area. They won't ventilate as well. So as a result, CO2s we've determined is normal between 35 and 45 millimeters of mercury. But you'll see COPD patients with CO2s of 45, 55, 65, 75, even higher. Some we've even seen that are cognitive and coherent up into the hundreds for a partial pressure. So CO2s of 100 or 105 are still alert and oriented. So for those patients that are CO2 retainers, we have to be careful with the judicious use of oxygen because they're thought to be working on peripheral chemoreceptors. So at the same time that their CO2 goes up, we all know from chapter 3 with the alveolar gas equation, as CO2 goes up, the alveoli don't have as much capacity to hold oxygen. So as CO2 goes up, oxygen has to go down in the alveolar environment, right? Higher the CO2 is, the lower the PO2 necessarily has to be. So as CO2 goes up, oxygen goes down, and as oxygen dips down below 55 or 60, then it stimulates peripheral chemoreceptors to ventilate more. So if we give COPD patients enough oxygen to raise their PO2 above 60, then their peripheral chemoreceptors suggest that they don't need to breathe any longer, and they'll specifically hypoventilate due to oxygen. So we call that oxygen-induced hypoventilation. Okay? So PO2s above 60 for chronically high CO2s can cause oxygen-induced hypoventilation. But it doesn't occur on every COPD patient. Every COPD patient won't necessarily behave and respond that way. So we have to watch and document which ones do respond that way. It's interesting in the hospital, when you get into a working situation, you'll see that one patient that comes in and every time you give them more than 2 liters a minute, they hypoventilate. So they'll be known CO2 retainers. And so one of the things that the text points out is that hazards of oxygen therapy in patients with chronic hypercapnia and hypoxemia. So when they have high CO2s and low PO2s, I'm not suggesting that every patient with chronic hypoxemia and hypercapnia will respond this way, but you'll know the ones that do. There will be a history, and we'll recognize those particular patients when they come into the hospital. So they all don't hypoventilate with the use of oxygen, but some can, and we'll be able to document which ones do. So keep your eyes out. Oxygen-induced hypoventilation, and it's usually seen in COPD populations. But remember that every COPD patient may not respond that way. Okay. Let's see. So peripheral and central chemoreceptors. And any questions then on how these particular spots in the central brainstem stimulates breathing? The pneumotaxic center is associated with panting type respirations. It's a lower order in the ontogeny of human development. You know, I don't know if you've ever heard the term ontogeny recapitulates phylogeny, and what that means is that in human development we all go through specific developmental characteristics of lower order animals towards humans. So you've probably heard that there are times in human development where a fetus will have a tail, they'll have paws instead of articulated fingers, and they go through they go through development, animal development in utero before they develop into full-fledged human. But the point of this is that as we go through human development, the lower order type of things occur in the pons, and so more primitive kinds of breathing patterns that we see, for instance, in dogs with that panting type respirations. What's the purpose of dogs to pant? Why do they do that?
Cool down.
The common knowledge is that they're doing it because they're hairy beasts. They need to find a way to cool down, and they cool down through respiration. So they fill their lungs up with air. We can do that too. In fact, when patients are in the hospital, we encourage them to take deep breaths, right, and to hyperventilate, or at least to use their lung volume to reduce atelectasis and to bring down their fever. So by ventilating, we can bring down fever. And so when you encourage patients on incentive spirometry, in a way, you're helping to use the primitive breathing techniques to help to reduce body temperature. So the pneumotaxic center in the pons is a lower order type of a breathing with the panting type respiration. Those sensitive neurons transmit to the apneustic center and controls and limits the gasping type respirations that we see when patients are suffering with low oxygen levels, or if they're near death and they're taking deep gasping type motions. So pneumotaxic is a panting type respiration. Apneustic is a gasping type respiration. Those are controlled and regulated by neurons that control the depth and rate and level of breathing. The main stimulus, though, is still from the ventral respiratory groups and the central chemoreceptors caused by CO2 in the CSF, not necessarily the CO2 in the blood, but CO2 gets into the CSF and then dissociates into hydrogen ions and bicarbonate. So the hydrogen ions in the bicarbonate is what specifically stimulates the central chemoreceptors. Peripheral chemoreceptors, on the other hand, outside of the brain, and they are oxygen sensitive cells. But the text points out, let's see if I can find it. Text points out that on second wind, which one is it? went, is it Leon? Oh, I think it was this clinical case that I wanted to relate here. And if you'll permit me, I'll just, is Kussmaul's respiration with hydrogen ions. So this is the second clinical application case that I was reading before class. I thought it would be a good example. So this is a 44-year-old unconscious woman on the living room floor. Her husband returned home from work. He immediately carried her to his car, drove her to the hospital. As he was driving, he alerted the ER from his cell phone and the medical staff that she was estimated about 15 minutes from arrival. While on the phone, the husband reported the wife had a long history of diabetes. He stated that his wife passed out 3 times in the past 2 years, so she's had a recurrent problem with diabetes. And he didn't know how long she had been unconscious before he found her. Upon arrival in the ER, the patient was still unconscious, breathing very deeply and rapidly. Emergency department placed oxygen on the patient's face and started an IV. Laboratory phlebotomist drew blood. The respiratory therapist obtained an ABG. And the ABG, this is a quite characteristic blood gas to see with diabetic ketoacidosis. Had 7.23. The CO2 was 24. The PO2 was, now this is on oxygen, is 405. That makes sense, right? The bicarb level was 19. So this patient is unconscious, has metabolic acidosis. So what's causing that acidic pH is a loss of bicarbonate due to ketones in the blood from the inappropriate metabolism of sugar, basically. So she hadn't taken her insulin. And what's interesting about this blood gas is that the human body knows that in this acidic state, in this metabolic acidosis, it's stimulating the central chemoreceptors to hyperventilate. So this one, the CO2 in particular, suggests that this is partially compensated. Remember back in chapter 6 and 7 on acid-base balance, we suggested that if a patient becomes metabolically acidic, that they'll compensate for that acidosis through ventilation. And what's happening here in diabetic ketoacidosis is that even though the CO2 is low, in fact, probably initially this was much higher, and so the patient was caused to hyperventilate, and that's related in their vital signs. The blood pressure was 135 over 85. The heart rate was 97, so they're not quite tachycardic. We would categorize that as 100. Respirations are 22 per minute, so it's not they're not overboard yet. They're not breathing too fast, but that 22 times a minute is causing a CO2 of about 24 through hyperventilation. So the patient has a partially compensated metabolic acidosis. And this is really common in diabetic ketoacidosis, is that the patient has a metabolic acidosis caused by the inability to metabolize sugar. And so the bicarb will rush to try to control the acidosis. So bicarb's low, it's a metabolic acidosis. As a result, then the central chemoreceptors control ventilation and try to limit the amount of influence that acidosis has on the human body. let's see, temperature was 37 degrees. Patient's respiratory pattern was charted by the respiratory therapist as Kussmaul's respiration. Do you remember that from chapter 3? Kussmaul's respiration. It's usually an increased depth and rate of breathing. So they're breathing deeper and they're breathing with more volume, and as a result of that type of pattern, breathing 22 times a minute, the ABG revealed a CO2 of about 24 millimeters. Good morning. 22 millimeters per millimeters of mercury. Let's see. So the respiratory therapist discontinued the patient's oxygen therapy. Why did we discontinue the oxygen?
Really high.
Well above what we need, right? I mean, we only need it to be 100, 80 to 100 at sea level. So we're always going to assume that our patients at sea level and at 80 to 100 is normal, even though we'll come to understand that 60 to 70 is normal here along the Wasatch Front. We're always, if we're taking a test, unless we're told otherwise, we assume that the patient's at sea level and that this should be 80 to 100. So the oxygen really isn't helping the patient. It's probably flooding her plasma with more oxygen than she needs. And we have to remember in subsequent classes we'll help you to understand that the oxygen is a drug and it does cause aging and other problems with cellular damage. So the respiratory therapist discontinued the oxygen therapy, and then they drew another blood gas. And the other blood gas showed, so after they took off the oxygen, it was 7.23. The CO2 was 24. The PO2 was 119, and the bicarb was still not 19. So the oxygen only served to flood the plasma with unneeded oxygen. Laboratory report showed blood glucose level of 837. Do you know what's normal? Less than 120. The text says normal is between 70 and 150. It depends on if the patient was fasting or not. So it's well elevated. The report also showed a serum acetone level of 1 to 64. That should be 0. The attending physician initiated insulin therapy. 2 hours later, the patient was conscious and talking with her husband. Her vital signs: blood pressure 122/68, heart rate 75, respirations 12, and the temperature was 37. ABGs, this is again 2 days later. 2 days later, ABGs were 7.41, CO2 was 39, PO2 was 95, and the bicarb was 24. That's an absolutely perfect ABG.
So does insulin help the bicarb come back up then?
It's not helping bicarb come up, but it helps to metabolize the sugar such that the ketones go down.
The ketones go down.
The acetone basically goes down. So it's not helping the bicarb in any way. It's an underlying metabolism that helps to reduce the ketones, hence the acidosis.
Okay.
So what's interesting about this is not so much the case, but the discussion that follows. And again, if you'll just permit me, the case illustrates clinical factors other than increased CO2. Now, usually it's the CO2 that affects these central chemoreceptors. So these are other cases other than CO2. Or a decreased PO2 that stimulates ventilation. Because the patient had not taken her insulin as prescribed, ketone acids start to accumulate in her blood. As ketone levels increase, the pH decreases, causing the acidosis, and excessive hydrogen ion concentration stimulates the patient's peripheral chemoreceptors. Because hydrogen ion does not readily move across the blood-brain barrier, the peripheral chemoreceptors played a major role in causing the patient's ventilation to increase. In addition, note that the patient's ventilation increased, her CO2 decreased. So that's why our CO2 here is 24. So initially it would have been much more acidic. You have to be able to understand, and we'll focus on this a little bit more next semester, but if this was 40, that the pH would be even more significantly acidic. Go ahead. Caitlin, were you going to say something?
No, I had nothing.
So if your CO2 is 40 and normal, the effect of the pH is even more significant. This would be 7.1 something. So then a metabolic acidosis, we partially compensate for that pH. Why is this partially compensated and not fully compensated?
pH isn't in range.
Very good. As long as the pH is still below normal ranges, 735 to 745, until this gets up to 735, then it's partially compensated. As soon as it gets to 735 or higher, it's fully compensated. Okay? So this is an example of partially compensated metabolic acidosis.
So when is it fully uncompensated then?
Never.
Oh, so, okay.
It'll either be fully compensated or uncompensated.
Or partial.
So partial. Does that make sense?
No, it's fine. I'll work on that later.
So when you didn't get it, Hannah. You
So
didn't
when
get
it's
it.
uncompensated, that range,
Starting to doubt.
that CO2 wouldn't even change at all either.
Well,
Like
when
it's
it's full,
uncompensated at all.
no, not necessarily. So if the patient had a metabolic, and there's an entire class, the first 4 weeks of next semester in January is fully devoted to just ABGs.
Love it.
So we're going to get more. It's not like this is the only, but we're starting to get an idea of how to make sense of this. So getting back to Jimmy's
Uncompensated,
example,
that's 40.
if the patient has metabolic acidosis and the CO2 is normal, it'll still be uncompensated.
Right.
Okay?
Yeah, that's what I'm
Until
saying.
this gets back to 735, then at that time it'll be fully compensated.
Right. I'm just saying if the pH is 7.23
Yeah.
and the CO2 is in normal range.
Yeah, if it's normal range, then it's probably not
Compensating at all.
Exactly.
Yeah.
That's exactly the point.
I have some pretty cool ones if you want to look at them.
Sure, you betcha.
Oh.
You want me to just
Oh,
write
that'd
it
be
down?
cool.
They're pretty cool.
If they're not cool,
These are
we're
the
gonna.
coolest
Okay.
values
Better blow
ever.
mine.
Fire away, Caitlin.
So pH 7.698,
Whoa,
Oh,
that's
man.
exciting.
CO2 20.1,
Wow.
PO2 132,
CO2 132. That is
bicarb 25.4.
25. So how would you make sense of that?
Holy shiznit, man.
Holy shnikey on
It's respiratory.
Jimmy Cricket.
that. Yes, exactly,
That's
Jimmy.
respiratory.
So bicarb is normally
Normal range.
22 to 26 milliequivalents. So this is right within the range.
Hyperventilating.
So we're not compensating at all. And how long does it take the kidneys to compensate?
24 hours.
24 to 48 hours, a day or two, before it starts to retain or excrete bicarbonate. So what's causing that 7.7 pH?
They're blowing off too much CO2.
Probably the CO2. So this is a respiratory alkalosis,
Uncompensated.
and how would we compensate for that alkalosis?
Bicarbonate.
We'd excrete bicarbonate, so this has to be down to 16 or so, to excrete enough bicarbonate to bring this back to 7.35 to 45. So because it's 25, it's uncompensated.
Uncompensated respiratory alkalosis.
Yep, completely uncompensated respiratory alkalosis. What's the other one?
It is 6.908.
Whoa,
Holy shit.
CO2 is
oh
11.5.
cool,
O2 162.
good.
Bicarb 2.2.
Oh man.
Whoa.
Yeah.
I told you guys.
So what the hell is going on there?
Holy
That's what I
cow.
wanted to know.
Where's the bicarb, dude?
Yeah,
Who's bicarb?
this patient,
Causing
you
problems.
ask this patient if they're diabetic, and the answer would probably be hell yes. So this is a diabetic patient. They have a metabolic, what's causing the acidosis? Is it the 11 CO2 or is it the 2 bicarbonate?
The low bicarbonate.
It's the bicarbonate, so it's metabolic, acidosis, And how are we compensating for this low bicarbonate?
Don't we have to raise this?
Yeah, by hyperventilation. Blowing our CO2 all the way off. You know, what if this was 40? What would your CO2 be if this was normal?
Even worse,
So you can already get a clinical picture. This patient is hyperventilating like crazy. They're breathing 28 or 30 times a minute to try to regulate the amount of base, you know, to make that 20 parts of base for every 1 part of acid, right? So they're hyperventilating like crazy. This is uncompensated, or no, partially compensated, Hannah. Partially compensated metabolic acidosis. And it's partially compensated because the pH hasn't come back to 735. So it would be a lot worse if the CO2 wasn't 11. This patient probably wasn't conscious. Was the patient
Were they
conscious?
conscious or not?
Yes.
Were they
They were in the ER though, and
they
it
were
was
alert?
like an emergency situation. But
Oh,
they
man.
were probably not super alert, but they weren't unconscious. They were just.
Okay, but they were on their way out. Yeah.
They went to the ICU, and
Okay.
the gas improved slightly after that when I drew it again.
What was it?
It was 7.042,
Oh, that's a lot better.
CO2 16.1,
16.
PO2 67.9,
Okay, good.
and then bicarb 4.2.
4.2. So here you can also see. Now, here's what's interesting about an ABG, and you'll do this the first 4 or 5 weeks next semester. Is that I can tell a lot about the patient by just looking at some numbers. I can tell that the patient's hyperventilating like crazy. I can tell that they're on oxygen because at this elevation you can't have a PO2 of 160 without being on supplemental oxygen. They were probably on a cannula or something.
They were
So,
on 100%.
oh, were they?
Mhm.
So he's still got quite a VQ mismatch.
Mhm.
If his PO2 is only 160, it should be like this other one, 400 on 100% oxygen.
Yeah.
So there may be some lung damage underlying from all that, aside from the current problem, which is diabetic ketoacidosis. It's a really great gas. It's really great gas. But you can imagine the stimulation that the central chemoreceptors are influenced to hyperventilate because of hydrogen ions. Yeah. They're so acidic that it's not the hydrogen ions per se, but it's the CO2 that gets across the blood-brain barrier and dissociates into hydrogen ions. Patients hyperventilating like crazy just to try to regulate the pH here. So we can tell a lot from just a few numbers, and that's you'll do example after example after example next semester, and you'll be able to learn a lot from just the numbers about what you expect a patient to be, and that's really that's the art of letting data and assessments and information inform you about how the patient should appear, what they look like, how they're breathing, what their heart rate is, what their respiratory rate is, based upon a few numbers. So we'll get more examples of compensated and partially compensated and uncompensated.
Yeah, these are super extreme though.
Oh, those are but you can see they happen. They do happen. So
Yeah.
when I see a gas like that, I immediately ask, you know, are they conscious? But secondly, is there a history of diabetes? And in 99 times out of 100, the answer would be yes. So what's interesting though is how they make sense of it. The reduction of CO2 was a compensatory mechanism, that is, the decreased CO2 worked to offset the acidic pH caused by increased ketones. In other words, if the CO2 had been closer to normal, around 40, in the emergency department, pH would have been much lower than 7.23. So back to this example. So if they don't hyperventilate the CO2, this is almost not compatible with life. It gets down into this, because remember, pH is the inverse log of the hydrogen ion concentration. That's a good question for the test in the next week. But inverse log of the hydrogen ion concentration, but it's also it keeps the pH within a fairly low range too, 7.35 to 7.45. So if you see at 7.9, 6.9, 6.8, if it's down around 6.7, patients usually don't survive that.
I've never seen that.
6.7 is,
Yeah.
So small changes result in huge swings in hydrogen ions. Okay, but we're measuring it in a fairly low range. So you start seeing 6.9, 6.8, maybe 6.7. Probably not going to survive that one. Also note that an increased respiratory rate does not necessarily mean the patient needs oxygen. In this case, however, such therapy was appropriate because the patient's rapid breathing until the cause of the rapid breathing was determined. When the results of the first ABG analysis were available, PO2 of 405, discontinuing of oxygen was appropriate. It was an appropriate response. What were they on in that second blood gas table?
60?
Oh, they were on 60%.
Yeah.
So there's something going on in their lungs. 60% with a PO2 of only 60 is very low. Saturation's still above 90, right?
98.
Because we associate on a normal curve, in an acidic curve, it should be higher. But in a normal oxyhemoglobin curve, a PO2 of 60 equates to a saturation of about 90. So unless we shift it to the right, then it would be perhaps even lower.
Yeah, satting 98 on that one.
So pretty interesting case about how hydrogen ions control breathing. We can tell where damage and lack of control occur in the brainstem because of certain types of respiratory patterns. The last point in the text Desjardins makes in how reflexes influence ventilation, and more completely how the impulses come back to the brain. Those are influenced by Herring-Brewer reflex, and in the next two pages, 378 and 379. Herring-Brewer reflexes are mostly associated and thought to be responsible for a yawn. So if the breathing pattern is shallow and low, or if class gets too boring, we'll open our mouth really wide like coffee. We'll usually stretch and yawn, and the thought physiologically is, although it's really not known, is to help to stretch and redistribute surfactant in individual alveoli. So it helps to open up previously closed alveoli by taking a deep breath. And then if you notice, the text even points out that we think that it's contagious. Now Jimmy's got
It
it.
is.
So I don't know if it's
I know, like when
contagious.
people, like when I yawn, like other people yawn too.
One after another.
Yeah,
If you
it's
think
weird.
about yawning, you'll eventually.
You'll
Yeah,
eventually
you
do
said
it,
yawn,
exactly,
like,
especially
oh.
if we're not doing much, like listening to boring lectures.
No.
So a yawn is associated with Herring-Brewer reflex, and so it helps to reopen, redistribute surfactant, open up the airways, expand your chest and your rib cage, and try to get more air and oxygen. So it's thought that, you know, if things are particularly slow or quiet, or we haven't taken a deep breath in a while, the Herring-Brewer reflex stimulates an involuntary reaction to take a deep breath. Okay, Herring-Brewer. Deflation reflex, we can stimulate those. When I was a kid, I bet, Jimmy, did you have a bunch of friends that would dogpile on top of you, and pretty soon there were 10 friends?
Mhm.
And so Jimmy's down there at the bottom with his deflation reflex being squashed. So if your deflation is squashed, it stimulates impulses to quicken and deepen your ventilation. So deflation reflex is triggered when you've got 10 friends deflating your alveoli. Your response is to try to hyperventilate and make the respirations bigger and deeper. Irritant reflex, those are stimulated when there are chemicals that cause irritations in the lungs. We see this every spring when patients come in having mixed Clorox and bleach, Clorox and ammonia together. Mix those two things together, it creates this gas that stimulates an irritant kind of a reflex, and it increases the respiratory rate and death. So there are reflexes in your lungs that when those irritant receptors are stimulated, it causes bronchoconstriction, coughing, sneezing, and increased respiratory rate. There are receptors in the tracheobronchial tubes in the conducting airways that are stimulated by certain chemicals. It triggers rapid, shallow breathing kinds of reflexes. Peripheral proprioreceptor reflexes are muscles, joints, and tendons that stimulate impulses to send back to the medulla, and those increase the number of respiratory stimulus to breathe deeper. The text reports those as stimulated during drug overdoses. And sudden pain, too. Pain will often increase the receptors to trigger respiration. Hypothalamic controls, cortical controls, and then carotid and aortic sinus baroreceptor reflexes. So those are all, it's an inclusive list. I think I might ask you about the Herring-Brewer reflex in particular, the others not quite so important. But it's important to note that there are reflexes that send impulses back to the medulla, and that influences the depth and rate and rhythm of breathing, controlled by ventral respiratory group's influence on central chemoreceptors and hydrogen ions again. That's going to do it, I think. Summary summarizes that up. And that finishes chapter 9.